I want you to do something right now. Just take a deep breath.
Yeah, just a normal everyday breath.
Exactly. And just trace the invisible journey of that air for a second. I mean, it goes in through your nose or mouth, down your throat, and drops straight into your chest.
Which is something we do thousands of times a day.
Right. Entirely on autopilot. But today, we're hitting pause on that autopilot. We want to map the literal architecture of that breath.
We really are. We are unpacking a pretty fascinating stack of material today to understand the central airways.
Yeah, we're looking at some incredible sources for this deep dive.
Oh, definitely. We're pulling from, well, the Hippocratic Corpus, Renaissance anatomical texts by Andreas Vesalius, and all the way up to modern ICU protocols, including this massive 2013 JAMA TrackMan trial.
Plus some recent CDC data on antibiotic stewardship, right?
Exactly. And our focus today is squarely on two fundamental medical roots, which are broncho and tracheo.
So the mission here is to understand how these very ancient words map onto the very real physical structures inside your chest.
Right, because it's not just about memorizing flashcards.
No, not at all. By the time we finish this deep dive, you will understand why a child swallowing a coin always seems to end up with that coin dropping into the exact same spot in the lung.
It's a very specific spot.
Yeah. And you'll see why ancient anatomists were spectacularly wrong about what the windpipe actually does. Plus, we'll look at how understanding just a couple of simple medical suffixes can decode the most high-stakes emergencies happening in an intensive care unit right now.
It really comes down to this principle of form dictating function and, how human language tries to capture that form.
Which is always a bit messy.
Oh, incredibly messy. We have to start with the language piece first. Because before we even look at the physical cartilage and muscle of the airway, the etymology of these words reveals basically a bizarre historical ghost story.
The word trachea is the perfect example of this.
Yeah, it really is.
Because if you trace that word back, it comes from the ancient Greek trachea arteria, which translates literally to rough artery.
Which is wild.
Right. To a modern medical student, or really anyone, calling the windpipe an artery sounds absurd. I mean, arteries carry blood, not air.
Exactly.
The Greeks were looking right at the windpipe, so why label it an artery?
Well, this stems from a really foundational anatomical error. If you go all the way back to the 5th and 4th centuries BCE with the Hippocratic Corpus,
Right.
and then later when it was systematized by Galen around 200 CE, you have to remember these anatomists were primarily studying cadavers.
Because they couldn't just, look inside a living, breathing person.
Right. And after a person dies, their blood naturally pools in the venous system. So the veins are visibly full of blood.
Okay.
But the arteries, they actually pump themselves empty as the heart stops.
Oh, wow. So when these ancient anatomists opened up bodies, they just saw these thick-walled arterial vessels totally empty of fluid.
Exactly. And they concluded, which, it was pretty logical for the tools they had at the time, that these empty tubes must be designed to carry air throughout the body.
That makes so much sense, given what they were looking at.
Yeah. So they use the word arteria as this blanket term for any air-carrying vessel.
But the windpipe is obviously a massive tube carrying air. How did they distinguish it?
Well, unlike the smooth blood vessels, which they also thought carried air, the windpipe is covered in these bumpy cartilage rings.
Right, it's textured.
Exactly. So to distinguish it, they called the windpipe the rough air-carrying artery, trachea arteria.
So trachea just means rough.
Yeah. And over centuries of medical translation, the actual word for artery was just dropped, and the rough qualifier alone survived. So today, we just call it the trachea.
That is so funny. It's like calling a koala bear or a seahorse a horse.
Oh, that's a great comparison.
It's this ancient, fundamental misnomer that just got permanently fossilized into formal language, and now it completely shapes how we talk about the human body centuries later.
And, a very similar linguistic evolution happened with the word bronchus.
Oh.
Yeah. In ancient Greek, bronchos just meant a windpipe in a very general sense. Galen used it somewhat interchangeably for anything in the throat or the airway.
Kind of a catch-all term.
Pretty much. But as anatomy became a more rigorous observational science during the Renaissance, that looseness became a huge problem. Anatomists realized they needed a precise, standardized map.
Right, you can't have surgeons just guessing what part of the throat you mean.
Exactly. So in 1543, Andreas Vesalius started narrowing the definition in his anatomical drawings. And by the time the scientific community established systematic naming conventions in the 19th century,
This was the Basel Nomina Anatomica in 1895.
yes, exactly, that's when they locked these terms in globally. They formally decided the trachea is the main pipe and the bronchi are specifically the branching tubes below it.
So they deliberately built an international scientific language.
Yeah. And that standardization is why the roots broncho and tracheo work seamlessly today, whether a surgeon is operating in New York, Paris, Berlin, or Madrid.
It operates as this universal language of medicine.
It does. Though there is one common linguistic trap in this system that catches people off guard.
What's that?
So the anatomical noun bronchi is inherently plural, right? We have a right main bronchus and a left main bronchus.
Okay, yeah.
And the trachea is anatomically singular. But when we use the combining root form broncho, it is completely number neutral.
Oh, I see.
Yeah, so a word like bronchoscopy doesn't specify if the doctor is looking at one branch or 20.
It just means looking at the branches generally.
Exactly.
Okay, so now that we have the historical context for why Renaissance anatomists locked these words into our dictionaries, we really need to map them onto the physical body.
Because seeing how this system is built really reveals how much the physical form dictates pathology.
Totally. And rather than just picturing an upside-down tree, I think it's more accurate to visualize this as this incredibly efficient fractal ventilation system.
Right, one designed to fit perfectly inside a rigid rib cage.
Yes. It takes a single high-velocity intake of air and distributes it across a massive surface area. And the primary intake pipe, the trunk of this system, is the trachea.
Which, in an adult, is about 10 to 12 centimeters long and roughly 2 to 2.5 centimeters wide.
Basically the dimensions of a garden hose?
Yeah, pretty much. But, a floppy garden hose would just collapse every time you inhaled.
Because of the negative pressure in your chest?
Exactly. So the trachea is reinforced by these 16 to 20 hyaline cartilage rings.
And hyaline is a really specific type of tissue, right?
Yeah, it's that glassy, wear-resistant, sort of bluish-white gristle you might see at the end of a chicken bone. It provides exceptional structural support.
But the really brilliant engineering detail here is that these are not full, perfect rings.
No, they are not.
They are C-shaped, meaning they are completely open at the back. And at the back of that C shape, where the cartilage is missing, sits the trachealis muscle.
Right, which rests directly against the esophagus.
Which solves a major anatomical real estate problem.
It really does.
I always picture it like a rigid travel suitcase that has a soft, expandable fabric panel on the back.
Oh, that's a perfect way to visualize it.
Yeah, so the hard plastic shell of the suitcase is the hyaline cartilage. It keeps the airway propped open, but that soft fabric back the trachealis muscle allows the esophagus to literally bulge forward into the airway space.
Because if the trachea were made of solid, complete rings of bone or cartilage...
Right. Every time you swallowed a massive, poorly chewed piece of steak, it would either get completely stuck or it would painfully grind against your windpipe.
Which would be terrible.
Yeah.
So the expandable back panel completely prevents that.
It's just this perfect compromise of structural integrity and flexibility.
It is. And moving down this intake pipe, we hit what is arguably the single most critical junction in the entire respiratory system.
The carina.
Yes, the carina. This is the fork in the road where the trachea splits. It sits right around the level of the sternal angle.
That palpable bony ridge on your chest plate where your second ribs attach.
That's the spot. But this fork is dangerously asymmetrical.
Highly asymmetrical.
Yeah, the right main bronchus branches off at a very steep downward angle. It drops roughly 25 degrees off the midline.
So it's shorter, wider, and plunges almost straight down.
Exactly. While the left main bronchus branches off at a much shallower angle, closer to 45 degrees.
And the reason for this structural asymmetry is just simple real estate, isn't it?
Yep. The heart sits primarily on the left side of the chest cavity, so the left airway is just forced to take a sideways detour to get around it.
Okay, but that steep 25-degree chute on the right side causes absolute chaos in the emergency room.
Oh, absolutely.
Which we will dive into in a moment. But tracing the airflow further down, the bronchial tree continues its fractal branching. The right main bronchus splits into 3 lobar bronchi, supplying the 3 lobes of the right lung.
And the left splits into 2 lobar bronchi, again because the heart is occupying the space where a third left lobe would normally be.
Right, and as the airways branch deeper, they get smaller and smaller. Segments, subsegments, all the way down to the tiny bronchioles.
And here is where the architectural integrity of the airway fundamentally changes.
Right, the cartilage fade.
Exactly. As you move deeper into the lung, you observe this cartilage fade. The trachea features those robust C rings. Then in the smaller bronchi, Those rings break up into irregular cartilage plates.
Kind of like cobblestones.
Yeah, sort of. And by the time you reach the tiniest branches, the bronchioles, the cartilage disappears completely.
There is zero cartilage.
None. It transitions entirely to smooth muscle.
Okay, looking at this structurally, I really have to question the evolutionary design here.
How so?
Well, we know the smooth muscle of those tiny bronchioles can undergo violent spasms, right? Like in a severe asthma attack.
Yes, definitely.
So why would evolution drop our protective cartilage and armor right at the exact anatomical point where the airways get the most narrow and vulnerable? It just seems like a massive design flaw.
It does seem like a flaw, especially when you're observing a patient in severe respiratory distress. But you have to consider the mechanical alternative.
Weird what?
Well, if you possess rigid hyaline cartilage all the way down to the microscopic alveoli where gas exchange actually happens, your lungs would be entirely stiff.
Oh, I see.
Yeah, they couldn't expand and contract with the massive changes in volume required when you exercise or cough or just take a deep breath.
So the loss of cartilage allows the lungs to act as a dynamic bellows.
Exactly. The unavoidable trade-off for that flexibility is vulnerability to smooth muscle spasm.
So flexibility takes priority over armor.
It has to, yeah.
You know, understanding that trade-off actually clears up a really frequent clinical misconception. People constantly blur the lines between asthma and bronchitis
They do, all the time.
because both conditions cause coughing, wheezing, and shortness of breath. But anatomically, they're entirely different mechanisms.
Completely different. Bronchitis, which you can hear in the suffix effixitis, is an inflammation of the inner mucosal lining of the bronchi.
So the tube is swollen and producing excess mucus.
Right. But asthma is a reversible spasm of that smooth muscle we just discussed. The muscle itself is physically constricting the airway from the outside.
Which gives us the decoding key for this entire vocabulary set.
Exactly. If you combine the prefix, which indicates the structure, with the suffix, which indicates the action, it reveals the exact pathology.
Right, so tracheomalacia. Tracheo is the trunk, and malacia means abnormal softening.
So the cartilage trunk is literally collapsing.
And bronchictasis. Broncho are the branches. Ectasis means abnormal widening or stretching.
Which means the branches are permanently scarred and dilated.
And bronchospasm.
Right.
The smooth muscle around the branches is actively constricting.
You've got it. It's a very logical system once you know the roots.
And just to quickly map the neighboring geography for everyone, air flows from the pharyngo, the pharynx, down to the laryngo, the larynx, and then into the tracheo.
Yes.
It's also really important to note that a pneumothorax, a collapsed lung, is a pleuro problem.
Right, that's an issue with the pleural membrane surrounding the lung.
Totally distinct from the bronchial tubes. The pipes are fine, the container is leaking.
Exactly. That's a great way to put it.
So returning to the architectural asymmetry we mapped out earlier, that steep 25-degree angle on the right side.
Ah, yes. The danger zone.
Because of this geometry in the cartilage fade, this specific neighborhood of the body is the site of incredibly high-stakes medical interventions. Physical form truly dictates pathology here.
It really does. This brings us to the foreign body in the right bronchus phenomenon.
Right. So if a toddler aspirates a peanut or swallows a coin or chokes on a piece of plastic, that object overwhelmingly drops into the right lung.
It's absolutely not a random 50-50 coin toss. Gravity and airflow pull the object straight down the path of least resistance.
Which is that wider, more vertical 25-degree right main bronchus.
Exactly. And it has direct bedside consequences. When a clinician evaluates a choking patient, the very first place they place their stethoscope to listen for diminished breath sounds is the right side of the chest.
But the danger isn't limited to just foreign objects, right?
No, not at all. The life-saving equipment doctors insert into the airway actually has to navigate this exact same treacherous geometry.
During an endotracheal intubation.
Yes.
Yeah.
If a physician pushes the breathing tube just a little too far down the trachea, it slides right past the carina and shoots straight down that 25-degree angle into the right main bronchus.
Resulting in a right main stem intubation.
Right. And then the ventilator ends up pumping air exclusively into the right lung, leaving the left lung to silently collapse.
Which is terrifying. And given that the trachea sits immediately next to the esophagus, separated only by that soft trachealis muscle we talked about earlier, how does a doctor actually know they haven't pushed the tube down the wrong pipe entirely?
Because pumping air into a patient's stomach instead of their lungs is rapidly fatal.
Right, so how do they verify it?
Clinicians rely on capnography.
Capnography.
Yeah. The moment the tube is secured, A monitor measures the exhaled carbon dioxide coming out of it.
Oh, because the stomach doesn't produce CO2?
Exactly. The stomach does not produce tidal waves of carbon dioxide, so capnography provides immediate biochemical confirmation that the tube is successfully seated within the respiratory tree.
That is fascinating, though looking inside that respiratory tree used to be nearly impossible, didn't it?
Oh, it was incredibly dangerous. The origins of bronchoscopy, which is the ability to look inside the lungs with a camera, are just staggering.
Yeah, our sources mentioned Gustav Killian in 1897.
Yes, he was a German laryngologist who essentially invented the procedure to extract a piece of aspirated pork bone lodged in a farmer's bronchus.
Which, at the time, was a celebrated medical first.
It was a massive breakthrough. However, the era that followed, which was dominated by an American doctor named Chevalier Jackson, involved procedures that are just difficult to imagine today.
Because to look inside the lungs, they utilized rigid, unlit metal tubes.
Yes, rigid metal tubes.
That sounds horrific. Doctors were literally forcing straight brass pipes past the vocal cords of awake patients.
Yes, off using just local anesthetics like cocaine.
That is wild. They were pushing unyielding metal into an airway that we just established branches off at sharp angles.
Exactly.
The physical trauma of trying to navigate a rigid cylinder around a 25-degree corner must have been immense. It sounds less like medicine and more like sword swallowing.
It basically was. The anatomy was completely unforgiving. If the physician misjudged the depth of the carina or attempted to force the straight metal tube too aggressively into that angled bronchus, the metal would tear right through the fragile mucosal lining.
Oh my God.
Yeah. Perforation of the airway, massive internal bleeding, and death were non-trivial risks for decades. The procedure demanded an incredible mechanical sensitivity to the body's resistance.
So when did that finally change?
It wasn't until 1966. A Japanese doctor, Shigeto Ikeda, completely revolutionized the field by inventing flexible fiber optic bronchoscopy.
Oh, thank goodness.
Right. He took the rigid pipe and replaced it with a steerable bundle of glass fibers that could bend with the anatomy and carry high-intensity light.
That single invention must have turned a deadly, high-risk ordeal into the safe, routine tool used globally today.
It absolutely did. But, even with modern fiber optics, when the airway fails, surgeons must sometimes bypass the mouth entirely and cut directly into the neck.
Which introduces a whole new set of terms that continues to create massive debates and real-world consequences in modern hospitals.
Definitely. The terminology here is precise, but casual clinical speech is not.
Right, because even medical professionals use tracheotomy and tracheostomy interchangeably, but the suffixes describe totally different procedures.
Yes, the suffix otomy signifies cutting into something.
So a tracheotomy is simply the surgical incision made into the trachea.
Exactly. While the suffix ostomy signifies the creation of a lasting, stable stoma or opening.
So a tracheostomy is the final product, the maintained hole in the neck, usually holding a breathing tube, designed to stay open for days, weeks, or even permanently.
Right. And that tracheostomy tube sits at the center of a genuine critical care controversy regarding exactly when to perform the procedure.
Like, if a patient is relying on a ventilator with a tube down their throat, at what point do you surgically cut into their neck and transition them to a tracheostomy?
Exactly. For a long time, the prevailing assumption was just to intervene early.
Because the logic dictated that converting a patient to a surgical airway within the first week would prevent complications like ventilator-associated pneumonia.
Right, and supposedly get them out of the ICU faster. It seemed perfectly logical based on physiological first principles.
But evidence-based medicine demands rigorous proof.
Always.
Which leads us to the 2013 JAMA TrackMan trial. This was a massive study involving over 900 critically ill patients across the UK.
Yes, and they compared early tracheostomy against late tracheostomy, where clinicians waited 10 to 14 days or more.
And the result completely subverted expectations.
Completely. The trial yielded a null result.
Meaning there was no significant difference in 30-day mortality between the early intervention group and the late group.
None at all.
Wait, but what was the physiological mechanism behind that null result? Why didn't getting the tube out of the mouth earlier save more lives?
Because the theoretical benefits of clearing the upper airway were essentially canceled out by the trauma of the surgery itself.
Oh, of course.
Making an incision into the neck introduces substantial risks. You have surgical site infections, bleeding complications, and just the sheer physiological stress of undergoing an operation while already critically ill.
So the TrackMan trial proved that rushing to perform this invasive surgical airway didn't provide a net mortality benefit in the first month.
Exactly. It forced a massive reshaping of ICU guidelines. It really serves as a perfect example of medical assumptions hitting the absolute wall of clinical data.
That tension between casual assumption and clinical reality is so fascinating, and I think it brings us to perhaps the most controversial use of airway terminology in outpatient medicine today.
The word bronchitis.
Yes, bronchitis.
Acute bronchitis is one of the most wildly overdiagnosed and overtreated conditions, currently placing a massive burden on the healthcare system.
But the anatomical definition is straightforward, right? It just means the inner lining of your bronchi is inflamed.
Right. It simply describes the physical state of the tissue, a state that occurs during almost any routine chest cold.
But the linguistic trap is the suffix itis,
It is.
because suffocatus sounds incredibly formal. To a patient, bronchitis sounds like a specific, severe bacterial infection that requires immediate intervention.
And the data published by the CDC on this is truly alarming.
Yeah, they run continuous antibiotic stewardship campaigns about this.
Because multiple large-scale studies demonstrate that the vast majority of acute bronchitis cases are viral.
A virus is causing the bronchial inflammation.
Yes. Yet, up to 70% of outpatients who arrive at a clinic diagnosed with acute bronchitis end up walking out with a prescription for antibiotics.
And antibiotics do absolutely nothing to neutralize a virus.
Nothing at all.
So is the sheer looseness of the word bronchitis in clinical speech actually driving the modern antibiotic resistance crisis? Just because the suffix itis makes patients demand a pill.
Essentially, yes. The suffix arachinitis gives the patient diagnostic validation. They demand a pill, and exhausted clinicians often just cave and write the script.
That is wild.
The vocabulary creates a very rigid expectation. Think about it. If a physician states you have a chest cold, the patient expects to go home, rest, and drink fluids.
Right.
But if the physician states you have acute bronchitis, the patient hears a medicalized disease state that demands a pharmaceutical solution.
So the language itself becomes a hazard to public health by driving the overprescription of antibiotics.
It really is a textbook mismatch between what a word means anatomically and how it functions socially.
Wow. We have covered a massive amount of ground here today.
I really have.
I mean, we started with ancient Greek anatomists trying to make sense of empty veins and cadavers, mapped out the fractal geometry of the lung, detailed the brutal history of rigid metal bronchoscopes.
Which I will never unhear.
Right. And ended up at modern ICU ventilator protocols and antibiotic resistance.
And it all shows that every time these anatomical terms are spoken, they invoke centuries of history, precise physical geometry, and immense clinical risk all at once.
They really do. So the next time you wake up at 2 a.m. to the sound of a child's croupy, barking cough, which is clinically termed laryngotrachea bronchitis.
A mouthful.
Yeah, or the next time you see someone use an asthma rescue inhaler, a bronchodilator, you aren't just hearing dry medical jargon.
No, you are visualizing a living, dynamic ventilation system inside the chest.
A system shaped by millions of years of evolutionary trade-offs, where we sacrificed rigid armor for the flexibility to breathe, leaving us vulnerable to spasm. A system mapped out by Renaissance anatomists trying to impose order on the human form.
And a system that continues to challenge modern physicians every single day, forcing them to navigate its sharp angles and fragile tissues.
It leaves me with one final thought to mull over, circling all the way back to our starting point. We know that the very root of the word trachea stems from a fundamental, spectacular, ancient misunderstanding about arteries carrying air. It forces the question, how many other foundational words in our vocabulary, whether they are medical, scientific, or just everyday terms, are actually just fossilized mistakes? What else are we currently accepting as absolute truth without ever stopping to question the flawed origins of the language we use to describe it?